CommHIT.
Let's extend another warm welcome as Deputy Chief Stephen Shaw returns to the stage, and he's going to be moderating a panel on Florida's mobile integrated health landscape.
Thank you, Kendra. So, real quick, I'm going to define mobile integrated health real fast. So, according to AI, this is it from Wikipedia or AI or something. Mobile integrated health is a patient-centered approach that delivers healthcare services outside the traditional hospital settings, often in the patient's home or other mobile environments. Here's another one. Mobile integrated healthcare is a patient-centered, innovative delivery model offering on-demand, needs-based care and preventative services delivered in the patient's home or mobile environment. What do you think? Yes, no, maybe? Here's the thing about this. When I read these definitions and you're looking through them all through the websites and your different platforms, my favorite thing about the mobile integrated healthcare platforms is no matter where you go, no matter which one you look at, they're all different. And that's by design. Because everywhere you go, they're given birth from the needs of the communities in which they're created. That's the beautiful thing about it. In the fire service, we often say that for us, firefighting is local. You know, depending on where you work, depending on where you're at, sometimes your tactics and strategies are dictated by the area in which you serve. And this is no more true in community paramedicine and mobile integrated healthcare. So, I wanted to say a couple words here before we invite our panelists up. And I will say that I'm very indebted to the panelists that are up here, not only Kendra, but especially to Lauren and to Jane. As we were starting our healthcare, our mobile integrated healthcare program in Fort Lauderdale, they were absolutely instrumental, doesn't even describe the word, and the information they were able to provide us as we grew. So I will always love them. I will always owe them a beer in some way or shape or form. So if we can call them up, so if we can have the, oh, I have a clicker. I have a clicker. So I'd like to call Lauren Young Work. She coordinates the Mobile Integrated Health Program at Palm Beach County Fire Rescue. Lauren has a master's in social work from Florida State University and specializes in illness and disability, medical trauma, and bereavement. For 31 years, Lauren has provided counseling, crisis intervention, and care coordination in health settings. Lauren is nationally recognized for her work in MIH in the program development and integrating social work into EMS and MIH patient care. Lauren wrote the first ever chapter on psychiatric emergencies for the National Association for EMTs and is an international exam workbook and textbook. Thank you, Lauren, for being up here. I'd also like to introduce Jane Bedford. She began her journey in first response at the age of 18 with the volunteer fire department after earning her paramedic license. She started her first job with Citrus County EMS. Over her 48-year career, Jane has worked in various EMS systems, including nonprofit, for-profit, hospital-based, and fire-based. Jane has dedicated her entire career to improving patient outcomes. Currently, she oversees the EMS Community Paramedic section of the Florida Department of Health. In this role, she develops strategies for a statewide community paramedicine program that addresses local community needs, reduces care costs, and prevents avoidable emergency room visits. And of course, our wonderful Kendra is a nationally recognized leader with 25 plus years experience in remote care innovation, combining community health and technology to address critical needs and build resilience. As CEO of CommHIT, Dr. Siler designs programs that lead to a tech and health workforce that is capable and adaptable in everyday and emergency situations. She's an appointed advisor for both the first Trump and Obama administrations. Dr. Siler has a PhD from the University of Florida, specializing in immunology, biochemistry, and with a postdoctoral research at the McKnight Brain Institute. Welcome, panelists. So let me break down how this is going to work. So as always, when anything comes to play with MIH community paramedicine, there's always more stuff that we want to talk about than the time allotted, everywhere we go, right? So I have a few questions that I think are going to spur some really good discussions here on stage. Afterwards, I 100% guarantee you're going to have follow-up questions, interactive discussions are going to follow in the whole 9 yards. We encourage that. I don't know if we're going to get to that in the half an hour we have. I'm pretty sure we're not.
Not with me up here.
Yeah, but that all being said, these folk are a wealth of knowledge, and they're here for every one of our programs, every one of the people that are involved here. I encourage you to seek them out afterwards. We don't get the time to answer your questions on stage, to really just get to know them, if you don't know them already, and just dive into their knowledge bases. They are just wealths of knowledge. Anyway, so My challenge is going to try to keep this within that 30-minute time frame. I probably will get there, but that's remain to be determined. So if each of you can give 3 minutes to define and introduce your work and give some key initiatives in what you're doing these days. So we'll start with Lauren.
So, hello, good afternoon, everyone. Thank you for having me. Again, very difficult to encapsulate in 3 minutes everything that we do at Palm Beach County Fire Rescue, but I think that what we're most well known for is really focusing on an interdisciplinary, multidisciplinary model of care. We were, if not the first, one of the first MIH programs to integrate clinical social work into our model. And we have seen that grow tremendously in the state of Florida and across the country, which is something that I'm very excited about. I think anyone who works in MIH would agree that social determinants of health and issues related to social services are a major factor for many of the wonderful patients and families that we serve. And so some of our initiatives at Palm Beach County Fire Rescue that we're currently working on is going next level by bringing, first of all, getting back to some of the things we were doing before COVID. Everyone can remember ET3 and all of that good stuff that kind of went away, and COVID kind of had us off track as special ops of EMS. And so, what we've been able to learn from those lessons during COVID, as well as some of that preparation for programs like ET3, is that there's a lot of opportunity in MIH to go next level. And so that's what Palm Beach County Fire Rescue is doing right now. We're taking that multidisciplinary model, and we're going next level with things like onboarding telemedicine, getting back to doing labs, getting back to doing more consistent care coordination model where we're following patients over a little bit of a longer period of time. We're doing co-response to the ED. We're looking at frontline, integrating some partnership with our frontline with fall trucks. With our MIH personnel. So there's a lot of things that we're doing to just try to go next level and take it beyond just being in the patient's living environment, but also being able to advocate and partner with patients and families in emergency rooms and in physician offices and places that traditionally MIH hasn't been as focused on.
Awesome. Well, thank you very much.
I think I was under 3 minutes.
You did amazing.
Okay.
I mean, yeah.
I can't promise you on all questions that will go that way.
So, Dr. Siler, same questions, but you do a lot of stuff. Let's say it lightly. She does a lot of stuff, right? But specific to MIH, same question. So, define and introduce your works on some key initiatives related to mobile integrated health.
Yeah, so I've never ridden on a box, so I don't come from fire rescue, but I started very early in fire rescue. So, first I started doing my postdoc at the Brain Institute. I was doing neuroscience, and I left that because there was a rural health organization. It was a network where they're trying to build up the community, and I was so intrigued by that I picked up and I left, and I took over as director at that rural health network. That's when I actually met Jane. So that was like
a long time.
Yeah, a really long time ago. So, and Jane actually was my first kind of encounter with mobile integrated health, because they had a community paramedicine program, and that was part of the service area that I was in. And I was like, this is the best thing I've ever seen especially for a rural community, to be able to make the care continuum better, and all those connections, like back and forth, like after somebody's discharged from a hospital, to have fire rescue, to be able to see that person's status after that. So it was really good for care continuum. It's also very good for people who are doing emergency care that typically they see somebody, there's nobody to thank them for what they did. The person is forever grateful, but they never get to follow up with what actually happens with that. So we started trying to work together on that, but the state just did not have an appetite for it at that time. And like I said, this is like, Stone Age pretty much. So am I at 3 minutes already? So I'm going to be quick from here. So anyway, fast forward, COVID happens. MIH all of a sudden is a hot thing in the state. So I get a call from the Bureau of Emergency Medical Oversight, which is at the Florida Department of Health, and they're like, hey, can you write this grant for us? Because we want to do this work with mobile integrated health. We're already doing a lot of work with community health workers. So we're like, okay, why don't we cross-train with community health work? We can build in, probably some Medicare reimbursements and other pieces. Like, let's just all put our heads together. Why don't we do an apprenticeship program where they get all the way from nothing to EMT and firefighter level 2 and paramedic into community paramedic? So Jane says, well, we're doing a program with community paramedicine and we're doing training with that. So I'm like, okay, I'll do the grant. So we do the grant, we braid these funds together, and now we're able to provide implementation plans and expansion plans for communities that want to do mobile integrated health. We're able to train their people on community health worker, get community paramedic training. So it's really just been a way to put things together across the state. Laura and I met more recently at MSAC meetings, and I have been actually following you guys with the work that you do in Palm Beach County, but it seems so unreachable for some of the rural counties. But now it's getting more reachable. So, we've gotten to work now more together, I think.
And don't forget, Palm Beach County actually has rural areas.
You do. And Palm Beach County is actually part of our grant. So let me mention real quickly, now I've turned into Lauren, because I'm the one going over. But I do want to mention real quick, you guys have 15 people now in our community health worker program that's going through. So we don't only work, just for the rural areas. We work for everybody, but we want to make sure that we're all working together. This is not something that you can work on in a silo and expect that you're going to fully help your community.
And Jane, please take a couple minutes to define and introduce your work and some of your key initiatives.
Can I just say what she said? I mean, no. So I work for you, everybody out there, and a lot of you I have worked with. So I just want you to know that this is a dream come true for me. When she talks about 15, 20 years ago, when a little guy named Jimmy Crutchfield and I started the Florida Initiative for Community Paramedicine, and we met with our legislators, and we met with Medicaid, and everybody said it was the best thing they ever heard. We met with the payers, and they're all like, great idea, but nobody wanted to come off any money. So here we are, 15, 20 years later, and I think people finally get it. So I'm here for you, my team and I, and some of us at that table back there. We will do whatever we can to help you get to where you need to be to start your MIHCP program. And you got my history. You're like, I'm old as dirt. I think Daryl's the only one close to me, so. I'm kidding, Daryl, but we did sit beside each other for a long time. But anyway, so that's it.
Thank you for those introductions, ladies. So I got a few questions here. One I'm going to turn to Lauren first off. And the question is, and it's about success stories and key lessons, but I would really like to hear from you the key lessons. We all have success stories. You have a bunch of success stories, but I think more importantly to the entire group are the lessons that came from them. So if you can describe some of those key lessons from your current initiatives or past initiatives, we'd love to hear those.
So I want to focus on three things. The first thing, and these are not in any specific order, but the first thing is about diversification. So when we first started our program, and I see this across the country, I'm blessed to be able to speak to programs across the country. We oftentimes are focused on one or two service areas in our MIH program. Maybe it's from a grant or some type of opportunity that we've had through our municipality or our funder source. And what has become very clear to me, and I think it's more important than ever right now at this time that we're in, is the need to diversify how you organize your program so that you're not dependent on any one funding source, so that you're not dependent on any one service line. At any time, the priorities of your community may need to change. At any time, the politics of your community may change. And at any time, stakeholders may come into your world. And so it's very important that we talk about diversification in MIH and how we can harness diversification to help elevate our programs rather than look at it as something that might send us off course. So that's the first thing. And the second thing is the multidisciplinary nature of healthcare. I was just talking to my bestie in the back, Joe Nelson, about this, that we in healthcare, if you come from any other area of healthcare, it is heavily entrenched in multidisciplinary care. And EMS has been traditionally not so. There's EMTs and paramedics. Everything is around paramedicine. In recent years, we've seen, of course, onboarding of nurses, especially in our flight medics. But there's really been a slow movement towards multidisciplinary care, and I think MIH has really shown that just as with the rest of healthcare, it does take a village to take care of a complex patient, and most of our patients and families that we serve are complex. That's why they're working with us. And so that's the other lesson, is I believe more than ever. I didn't know what would happen 9 years ago when I came into the MIH and EMS world, but I believe more than ever in the need to also diversify our teams and the importance of all the different roles, nurses and PAs and nurse practitioners and social workers and CHWs, people who have experience in public health and technology, paramedics, EMTs, it all comes together, and physicians. It all comes together, and it is critically, critically important to the success of our programs. And if we don't have those people in our programs, to find stakeholders to work with us. And then the last thing I would say, and this is kind of an outlier that you probably don't expect me to talk about, but it has to do with business prowess and business know-how. A lot of us who are working in healthcare have no experience whatsoever in business. That's not our forte, it's not our training. We see someone needs help and we find a way to help them. And we're willing to do it for nothing. That is how we are. We see someone who needs something and we go for it. And so here we are in MIH, and you're talking about funding, Jane, and some of that, element of sort of people starting to get it. And I think you're right, we're on the cusp of that. But as part of that, I've also learned that we need to empower our industry, I'm talking about MIH in general, in how to market ourselves, how to sell ourselves, how to function in a business environment, because EMS isn't used to that. We're used to kind of being unto ourselves and running our agencies. We're not used to having to go outside and sell ourselves. EMS sells itself. And so I think that is a critical element in MIH that we're gonna start seeing emerge heavily over the next few years, is how can we help our MIH leaders become more business proficient. And I think that's going to be critical to the success of MIH moving forward.
Wonderful, thank you for that. So Kendra, question for you. Money is tighter than ever right now. What are the current or upcoming funding opportunities for mobile integrated healthcare development or training?
And this one, I think you're going to have to help me on that a little bit too. That's a really good point that you're making, and I think it's a great segue into this. How are you not just kind of filling in gaps, but you're turning this from a cost center into something that's recognized as adding value? Things that CommHIT tends to do, there are things that add value, there's ROI, but we're oftentimes finding the things that if it's not working, people notice, and if it is working, they don't say anything. That means that you're doing a great job. It means you're doing it over 100%. So like cybersecurity, for instance, like everybody's happy until something happens to the computer, but they don't really want to put budget into those things because they don't really see the value in it. It's not something that makes them happy. It just makes them upset when and if something goes wrong. So I think MIH almost falls in that same bucket, and we do need to be able to eloquently communicate, what really is the true value of MIH, not just in the local regions, but in the state, also federally, to get money put at least into the right places where there are still gaps that others can't really serve those gaps. In terms of us, we got a $1.5 million grant. That one's actually sunsetting soon, but that was the one where we were able to create a lot of implementation and expansion plans that people are able now to show to their counties, get grants, work with it as they move forward. So even though it was like a one-time thing, it's something that became a living document for them. Also, we help them with training. We help them kind of gather their community, get together with the type of people that needed to be there to start these MIH program seeds. Now that grant is sunsetting, we have a $4 million grant where we're moving into apprenticeship programs for that, where there are community paramedics, where there are more people even trained with community health worker that they don't have to go through the apprenticeship program, but that's also part of that grant. Again, it's all about braiding funding and braiding resources in a way to where you're filling in gaps. And this is what I did, you know, as a researcher. I was always looking at biochemical pathways and what changes what, and where do you fill gaps, where do you end up with gaps if you do certain things. So it is a delicate balance with technology, people, and processes, but you know, certainly we're here to do that. Just last quick point, something that we're also moving into now, where we're becoming a little bit more advanced, especially in the rural areas, and moving in your direction, is trying to get nurses infused into some of these programs. So some of the apprenticeship programs are more for nurse infusion into community settings for mobile integrative health, and we're also bringing in our partners that are either technology partners or those that are already kind of doing this work in extreme environments and using technology, so we can then integrate technologies into these programs where it can work in communities.
Wonderful, love that. So Jane, now you've had this interesting experience in your position to see multiple programs across the state. So I think your perspective is probably something that's highly, highly valued. So this question is for you. What are some creative mobile healthcare solutions that bring care directly into people's homes? And how can these innovations address challenges like chronic disease management or emergency response?
Okay, they do, and they do it all across the state, as you know. All of that has been expressed about the uniqueness of each program for each area, and whatever that gap is that's identified, that's usually what organically grows for the community paramedic or MIH program. They meet the gaps, and that's what makes them successful. I could tell you so many stories, but I know you don't want me to talk about it, but I'll just share one small little community paramedic program. They only have, this might tell it for you, they only have one ambulance in this community, and they don't have a hospital in their community. But they started their community paramedic program with our help, and they met a person who had no services. Neither did they have electricity. So he used his vehicle's hotspot to get this one person hooked up to services. Now that's not quick. That was an 8-hour day with no air conditioning because he wanted to sit with her. She was so thankful that she gave him her last Coke. She said, "This is the last Coke I have." And he said, it just impacted him so much, he's talked about it several times. But it's reaching those people who are not touched and bringing healthcare to them. That's one of the things. But I want to speak to what Lauren said and to what Kendra said about how we prove these programs, and it's through data. So one of the things that I'm working real hard to do in the state of Florida is to jump up and down and say, this stuff works. Let me show you the ROI. What do I need to show them the ROI? I need the data. So that is one of the big projects we're working on now, is collecting data from all the agencies so that we can show value for these programs. Did that answer your question?
I think so. I mean,
Okay.
I think that the interesting thing about these questions is it's generating more questions. Like even I'm writing notes as I'm up here, you know, like I got to ask about this later and this later. But anyway, since we only have a few minutes left, I wanted to ask each of you about what you feel is the future of mobile integrated health. So the last few minutes we have here, each of you give us your perspective on what that looks like in the future. Lauren?
In Florida or nationally?
You choose.
So I'm going to talk about Florida because Florida is near and dear to my heart and everyone in this room. So for Florida, I think that we have really set the stage for honestly being the most innovative in terms of multidisciplinary integration within our teams. I'm consistently and constantly impressed. You know, we went from 1 or 2 programs 10 years ago to I think 81. Almost to 90 programs. So the explosion of growth and hearing about the different program models, again, we all do it a little differently, but I think that we really are leading the way across the country in terms of having that multidisciplinary integration. In Florida, because I think we're so advanced in that area, what I'm really expecting for MIH in the future is for MIH to really go beyond where we are now, to not only fill gaps and help serve patients and families where we see that they're having issues with access or health equity or social determinants of health, but that we're going to be able to take it a next level and create partnerships in our communities who are doing great work now, but they are experiencing gaps. So it's not necessarily the patient, it trickles down to the patient, right? But we have a lot of health systems in the state of Florida who are experiencing gaps. They don't know how to fill them, and they want to do the right thing by those patients. Everyone wants to do the triple aim, right? We want to improve the patient experience, look at cost, and also help with community health. So I think for the state of Florida in the next 10 years, beside the awesome data projects that we're going to get off the ground and be a leader in, I really think that because we already are on board with the multidisciplinary piece, that we're going to see incredible stakeholder partnerships born out of the state of Florida that will be a model across the country in a way that I think is going to really elevate the state of Florida to being one of the lead states in terms of mobile integrated health innovation. And I'm really excited to see all of that unfold. We're seeing it start now.
Love it. Thank you for that. So Kendra, what about you? Future of MIH?
Yeah, so from what Jane and I, we're on the federal calls for our grant, and from what we're hearing, we're actually way ahead of what a lot of people are doing nationally. And I think that one of the important pieces of that is having the mobile integrated health associated with fire rescue. A lot of the other states are associating their mobile integrated health with hospitals, and I don't think that that's bad. But I think that people are used to and trust fire rescue going into their home and helping them. So you already have this built-in trust with somebody coming to your home and working with you in your home that I think is a big deal. I think that the pieces that are going to kind of move forward in Florida, I think the nation's probably going to start adapting to this fire rescue kind of mobile integrated health connection instead of the hospital. But for us moving forward, I think we're going to become more sophisticated in how fire rescue works with medical providers and how they get money in from doing mobile integrated health, whether it's social determinants of health or any type of case management that's needed or other types of work that they do in conjunction with hospitals, in conjunction with providers. So I think it's going to become a more kind of integrated part of the healthcare system, like instead of being like a not traditional kind of form of healthcare. And I think the last thing is that mobile integrated health is definitely going to be informing space travel, because that type of kind of care model is really important just for the general care of people, especially for non-emergency things.
All righty, thank you for that. And Jane, the same question. What's the future of MIH look like from your perspective?
So hopefully it has a lot of data to support it. And it will. I know it will from what we're doing. But I think that what we're going to see is programs that are improving the health of their community. They're relieving the stress of the fire rescue and EMS services that have to get up 30 times in 1 month for one lady who falls. They're going to fix that program for them, and that's going to make them happy. Believe it or not, there's some people who don't really understand how MIH fixes that problem. So we still need to do some education. We need people to understand how these programs work. We need to demonstrate the ROI, and we need to show people that this is a solution for everyone's problem, not just fire rescue, not just the hospitals, but for the community's health, that MIH CP programs addressed all those public health issues.
Okay. So I do have a few minutes. Kendra, is it okay if I take one, maybe two questions in the audience for you guys to answer? All right. Yeah. So while we're here, we got a few minutes left. Are there any pertinent questions that anybody has related to MIH or to picking the brains of some of the people up here? Anything specific or just things that are roaming through their head? I'll tell you, the notes that I have, if it stirs some energy, integration, collaboration, filling gaps is always a huge thing. Aligning priorities, probably something that all our programs need to do. The uniquely positioned nature of fire rescue in these programs. Anybody have any questions?
Hi, I just had the one question with regards to business skills. You were mentioning that there's not enough. A general business may not get to what you want. So can you be more specific in terms of the types of skills?
Absolutely, that's a great question. So marketing, Marketing is definitely one element to the skill set that I think is needed. How to do an elevator pitch is a very basic, simple skill that a lot of individuals don't have who are coming from a healthcare environment. And, it's funny, I think about, being and also understanding some of the terminology, I should say, of our stakeholders. So you talked about ROI. Everyone in the room may not know return on investment, right? So there's basic terminology in business that when you're talking to hospitals or federally qualified health clinics or ACOs, the accountable care organizations, they may use language that is business oriented that we do not understand, just like they wouldn't understand what BID means, or what Q day means. They don't know medical terminology. And so I think we need to have some crash courses. I look at it similar to the CHW. I'm a licensed clinical social worker. It took me a very long time, a lot of schooling to become an LCSW. A CHW, a community health worker, is not the same as someone who has a master's degree and a clinical license, but they're provided with a basic level of education where they're able to do what they need to do to begin to help that patient, and then they can refer to a higher level of care if needed. And so I look at it in the same way. We need to offer some basic training for our personnel in MIH and quite frankly in EMS on these types of business knowledge elements so that we can better advocate, sell ourselves, promote our programs, both to government stakeholders as well as stakeholders in the health community, insurance companies, and honestly, we're going outside the box, right? It's not just that anymore. There are so many different stakeholders coming out of the woodwork. We're talking about technology. There's technology companies. But if you don't speak their language, it's hard for them to understand what you're asking of them. And so I think that's very important to help people understand how to speak their language.
That's a phenomenal response. And
he has an MBA, so I'm going to thank you.
You're welcome.
You're one of the rare people who has a business background in EMS.
I'm a school nerd. That's all that means. I have no life. Okay.
But it's still. But don't you think it's been a benefit?
To your point, 100%. Everything she's saying, I'm thinking about as we started our program in Lauderdale, going, man, I wish I had that knowledge back then, that language back then, because you can speak passionately about it all day, but if you're not explaining their language, they're like, all right, make it make sense to me. What's the ROI?
Cost avoidance.
Define value.
What is cost avoidance?
So.
Yeah.
One more question maybe? Or
sure.
Anybody have one final question to wrap it up? Yes, sir.
Hey, Jane.
Hi.
Oh, hi. At the last MSAC meeting back in January, we heard the department say that the department and NACA were partnering to hire someone to take a look at an actuary, I guess it was, to take a look to determine the return on investment and the impact that MAH programs are having. And is that still coming? We were told that probably in May, but you know how government works. So is that still coming? Are we going to actually get a professional report that says what our return on investment is these days?
Yes, it is. 2 studies are being done right now, and they're both phenomenal, and I can't wait till they come out. So yes, they are coming.
Kendra?
Well, I know we have Aki here, but I'm not sure if they can speak exactly to that today. So I don't have anything to add to that piece.
Well, in that case, we're right on time then. How about that?
All right. So is this an incredible panel?